Okay, hello everyone. By my clock, I have it's promptly 12 o'clock, so we will get started right now. This is Epilepsy 102. It's a follow-up to the Epilepsy 101 that was given in January. This series will be repeated again in March and April, with March being Epilepsy 101 on Thursday, March 26th. And Epilepsy 102 will be repeated on Thursday, April 30th. So let's get started. We are looking more in depth into diagnosis, treatment, and the impact of epilepsy that it can have on a person. So the first thing we'll talk about is diagnosis. How is epilepsy diagnosed? And I forgot to do I will have resources that I will email you afterwards because I see that I omitted to attach them as handouts here. But I can email things for more information if you are interested. So when we look at diagnosis of epilepsy, it's really not like a strep throat or some sort of other bacterial illness where they can do a simple throat culture and determine whether or not you need antibiotics. They really have to piece things together like a puzzle. And really, the most important piece, I'm not sure people realize how important it is the medical history that they collect from the person and or their supporters or caregivers around them is really key. Because oftentimes there are some forms of seizures that the person themselves will not know what is happening to them and what symptoms they're presenting with. So any observations by other people are key. And for parents of children with epilepsy, I think the smartphone, one of the huge advantages is if they have time and can grab it and take a video of their child exhibiting what they think might be seizure activity, that's a gold mine of information for the neurologist. They typically will do, particularly at the very beginning, when they're suspecting a seizure disorder, they'll do an EEG, which stands for electroencephalogram, where leads are placed on the scalp and they record the electrical activity of the brain. And they're looking at there's a normal pattern that everybody's brains have. And then when you see a seizure, it just looks like this jumble of real sharp spikes and things. So doctors that have become really skilled in reading these can actually see different spike and wave patterns for different types of seizures. And then, of course, the placement of the electrodes on the scalp is a map of which waves are being recorded in which part of the brain. Is it, the left hemisphere or the right hemisphere? Is it frontal lobe? Or is it at the back of the head in the occipital lobe? And then oftentimes when they want to find out if there's some sort of physical reason for the seizures to be happening, they'll do some sort of imaging tests, whether it's a CAT scan, a CT scan, or an MRI. They're looking to see if there are structural reasons, if there's something like a brain tumor or a lesion or scar tissue or a venous malformation. They're looking for something that would be, say, yep, this is what's causing the seizures to happen. And then some substance is present in the blood after people have seizure activity, so that they can also look at a blood sample if it's within a specified period of time after the seizure. And this indicates to them that there was a potential that, yes, this was definitely a seizure. All right. And as they pull these different pieces together, it really impacts how they choose to treat a person's epilepsy, because there are over 30 different meds that we have available to us in the United States. And treatment depends on the seizure type, where in the brain the seizure is starting, and how much of the brain is involved. Because there's some drugs that work really, really well on focal seizures, but they can make generalized seizures worse, and vice versa. So it's very, very important. Okay. So as I said, it's no one thing that they're looking at. And honestly, the gold mine is any description or video of the seizures that the doctors can, take a look at and incorporate into theirs. Which brings me to the importance of seizure tracking. So I have a handout. This is one of the resources that I neglected to upload, but I'll email to all attendees afterwards. It's an informational page created by Epilepsy Foundation America about why it's so important to track seizures, and that this is the information that helps the neurologist fine-tune the treatment plan. Okay, and it just dawned on me that this slide is an exact redundant. I don't know what I was thinking. I have two of the same slides. So moving on from diagnosis, once a diagnosis has been confirmed, and I will remind you that it is not common for them to diagnose after only one seizure. The neurologist must see such abnormal activity on the EEG that leads them to believe that there's a high risk of a future seizure. They typically wait until a person has a second seizure before they go looking and say, okay, this might be epilepsy, all right, before they choose to treat. So when they look at the treatments, it's our meds that are our first choices. This is what we're looking at, the anti-seizure meds. And there's some broad use ones that I'm sure you might be familiar with: Keppra, Dilantin, Depakote, that have like a broad application. For focal seizures, maybe it's Trileptal or Tegretol, that are in really high use. And that's our first go-to, because the way these medications work, and this is why people who take them often, particularly initially, will feel very lethargic on them, very sleepy, low energy, is because they dampen in one way or another. The way they control seizures is that they dampen brain activity, because they're trying to keep that brain from getting overexcited to that point where the electrical activity becomes a seizure, it becomes abnormal. And then, but the statistics aren't great. When we talk about anti-seizure medications, we really want to make the right choice, because if the first medication tried doesn't work, and they decide to either add a second medication or switch to a second medication, there's really strong studies out there that show about 47% of epilepsy patients will respond to that first or second medication. But once a second or third medication is added, only another 14% will achieve seizure control. And then once we get out third, fourth, fifth medication, only 3% of people will respond to medication. So sadly, that's putting us only at 54%. There's still, if my math is correct, there are still, or 64%, there's 36% of people for whom meds are not working. And these are the people that neurologists will say have drug-resistant epilepsy. And we really need to look at other choices for them, because the drugs just don't seem to be controlling their seizures at all. So then perhaps they'll try and explore and see if they're eligible for either a surgical intervention or some sort of neurostimulation device. And we have a few on the market now. So further down, I'll talk about each of those. Maybe some people are more inclined, the thought of brain surgery just is absolutely off the table for them. So maybe they might want to inquire as to whether a therapeutic diet such as the ketogenic or the modified Atkins can help them achieve seizure control. And then, of course, there's always clinical trials coming out where there are pharmaceuticals that are using investigational medications, trying to get the data that will bring them to FDA approval if they're successful in controlling the seizures. So there are a lot of people out there who have drug-resistant epilepsy that may say, yep, I am willing to be a participant in a clinical trial. And, there are ways, if that's something that interests you for yourself or for your loved one, you can reach out to the Epilepsy Foundation and we'll connect you with the people at National who keep a database of ongoing clinical trials. So, referring to the medications themselves, again, the neurologist has to pinpoint the type of seizure. And in order to determine the type, they need to know where in the brain and how much of the brain is involved in each of that seizure. Is it only one hemisphere in a very localized area, or is it both hemispheres? So it's a generalized seizure. And as I said, that determines what medication they're going to choose. They look at a person's age and gender because there are some medications that are less desirable to put women of childbearing age on because they are known to have a high risk of birth defects. So we'll probably try to put women on one of the other meds that do not have that as high a risk of birth defects before this one. What else? Oh, there's some drugs that have extreme weight loss as a side effect or extreme weight gain. So you might look at a teenage boy or girl and say, oh my God, I don't want to do this to a kid at an age where they're really self-conscious about their image and things like that. So they really do take all these things into consideration. Then they have to look at whether or not they have other medical conditions that they're being treated for and determine whether or not they're going to have drug interactions or any issues with them compounding, so let's say the cognitive effects or the lethargy or things like that. And then they want to look at tolerable side effects. So something interesting that people don't realize is that we really haven't found the miracle drug yet. That when we see all these new meds like Vimpat and Onfi and Benzyl and all these newer drugs that have only been out for, say, the last 5 or 10 years or so, it's not that they work better. Some of them might work a little bit better than the older drugs. It's that they have less side effects, that the pharmaceuticals have been really paying attention to quality of life and have been seeking out medications that won't have that sledgehammer side effect that maybe a Dilantin or a phenobarbital or a Depakote could have on a person. And by that I mean, people who, Dilantin came out, I think in the 1930s, and it was the go-to drug for anybody with epilepsy. But it has, when you've been on that drug for years, it has some pretty significant physical characteristics that come up. Excessive facial hair, that's not pleasant for a woman. It actually coarsens the facial features. That's not pleasant for either gender. It causes hypoplasia, which is an overgrowth of the gum tissue in the mouth. So there's things like that the older drugs, they have these really significant side effects that we want to move away from. So considering side effects, those can have a bigger impact on your quality of life sometimes than the seizures themselves. I know that might sound hard to believe to some, particularly if they have tonic-clonic, but I know people with focal seizures that say, my medicine has me down to 1 every couple of months, I'm okay, or 1 a month or whatever it might be for them. I'm okay with that as long as it's a small one. I know I can handle it. I just hate the way I feel on XYZ medication. So, but the stats are with us. As I said, about 7 out of 10 epilepsy patients, the medications do work for them, as long as they're compliant. I mean, there's always that. So for the people who might be a candidate for some sort of neuromodulation device, the oldest one, the one that's been around the longest, is the vagus nerve stimulator. And this device is implanted right under the skin. So you see this little pocket watch side circular thing that's implanted under the chest wall. And then there's a lead that comes. This generator is the battery, and it generates the signal. It's threaded up and around the vagal nerve. And the theory behind it is that when you send pulses up the vagal nerve, that it gets spread across the whole brain, widespread areas of the brain, and that it can potentially interrupt seizures or prevent seizures from starting. In addition, patients are given a magnet that they can either wear in a wristband, so it looks kind of like a watch, or carry elsewhere on their person, but they have to be careful. These magnets can cause havoc with debit and credit cards and smartphones, so you have to be careful not to store it too close to those areas. And they can actually wave the magnet over the generator. So even though this is programmed at the doctor's office to be on 24 hours a day, so let's say, for example, it's set to give a 20-second pulse every 30 minutes. I don't know what the settings are. I know they start very low and they amp it up. But it's on 24/7 working by itself. But they can swipe the magnet over the generator and send an extra pulse for those people that actually have an aura or a warning and they feel a seizure coming on, or a caregiver who observes the start of a seizure can go over and swipe the magnet over the generator and send an extra pulse to try and stop the seizure or at least dampen the severity of it. Really, I personally can't think of a single person who came off of meds with the VNS, but they still used, between their anti-seizure meds and the VNS, they actually are noticing a reduction in the frequency and the severity of their seizures. The next device that's been on the market, this has been around for probably about 10 or 15 years. I think 15 years ago, they started the clinical trials. So the NeuroPace makes a responsive neurostimulation. Now the problem, this one is a bit more invasive, but it does some pretty amazing things. So this little generator that you see is about the size, this is an accurate picture. If you hold your thumb up against this picture, it's about the size and shape of your thumb. And they do have to go in and remove a skull flap, a little piece of the skull the size of this device. And they're going to put this device right on the surface of the brain. And then they're going to use these electrodes. And you see two types of electrodes here. This one is called a grid. See how it has these 4 little circles? So this could sit on the surface of the brain like you see here, or very close to the surface if that's where they determine that the seizures are coming from. And this more probe-looking one is threaded into more interior, deeper parts of the brain if the area of focus happens to be deeper. Now, the amazing thing about this is that this little generator, it's not turned on sending electrical pulses, every hour of the day like the VNS one. This one is sitting there and monitoring the person's brain activity. It's like their own little personal EEG. And when the device senses a seizure starting in an area, it turns itself on and it sends a pulse down that electrode to interrupt the seizure and stop it from happening. So there's 2 really huge advantages to this. One is that it's interrupting the seizure right at its source. Now remember, the vagal nerve, it's kind of like widespread. It's like throwing paint against the wall. It's just kind of sending a signal up the vagal nerve that hits wide areas of the brain. This is more targeted. The second advantage is because it's a monitoring unit, once a week, these people are given this wand-like device that they actually wave over the device in their scalp, and it downloads their EEG, it downloads the information, and they send it via telephone lines to their neurologist. So they get a wealth of information about this person, but it is a much more invasive surgery. So, you have to examine the risk factors and what potentially might happen, things like that. All right. And they are finding that it really doesn't affect cognition, that they're really seeing some positive things to it. And as I said, it's ambulatory EEG information that's not available with any other advice. It's like your own little personal EEG system that's always with you. Now, the brand new to the market, oops, and I see a typo on my slide. There's an extra space. The T belongs down here with thalamus. Is a deep brain stimulation from Medtronics. And this is relatively new. They just got FDA approval last year. And it's for use in people who have uncontrolled focal seizures. They're not candidates for resection or other types of epilepsy surgery. And perhaps the RNS is not a good solution for them, and or they're kind of concerned about the invasive nature of the RNS. Maybe they already have a VNS, but it's not really giving them the seizure control that they want or the seizure reduction. Lots of reasons for them to look in this. And deep brain stimulation has been used for Parkinson's and other movement disorders for years. Well, the way it's used for epilepsy is very, very specific. So for people who have temporal lobe epilepsy in particular, what they're doing is this is the device that, like the VNS, is implanted under the skin on the chest. But this time the leads are threaded. There's going to be 2 incision points, and they'll be very small. The second incision point is to thread their leads down into a specific part of the temporal lobe called the anterior nucleus of the thalamus. And it's battery operated and programmed by the doctors and nurses. So like the VNS, it sends a pulse, but it's not sending it to wide areas of the brain. It's sending it to this very specific region. But temporal lobe epilepsy is the most common epilepsy syndrome in people whose primary seizures are focal. So there's a lot of people with epilepsy that have it. So this is, it's certainly worth something. And if you're interested in learning about it from the source more than what I can share with you, we are actually going to host a webinar on Wednesday, April 15th from 6:30 to 7:30 p.m. And a neurosurgeon, Dr. Mark Richardson from Mass General Hospital, is going to explain how it works and why they're hopeful for people that have uncontrolled focal seizures why this might be something worth looking into. Okay, moving on to the dietary therapies. So we see here the ketogenic diet. Now, years ago, originally, this was discovered in the 1920s. And it was discovered by doctors who were working over in third world countries. And they noticed that people that were going through periods of famine, that the people living with epilepsy would stop having seizures when they were starving. And they said, wow, I wonder what's up without that. So they come back to the Western world, whether it was the UK or Germany or the United States, and talk about barbaric. They would take people with epilepsy, put them in a hospital, and literally not feed them. They would starve them. So yeah, their seizures might cool down, but guess what? Starvation also has its own problems. There was a high death rate with this treatment of choice. So they didn't know what they were doing back then. But then they discovered that what was helping with the seizures was this actual, when you burn fat for energy instead of sugar or glucose, your body produces something called ketones, and it's those ketones that change your brain chemistry and have an effect on stopping seizures. So they started it with children in about the 1980s because a family discovered in doing research, it fell out of favor, and when we developed more medications to treat seizures in the 30s and 50s and 1970s, all these meds came out if you look out at what years they came out in. But in the 1980s, there was a family out in California that discovered it and said, you know, we want to try this in our son that has Lennox-Gastaut, because notoriously kids with Lennox-Gastaut have multiple forms of seizures that do not respond well to medication. They're drug resistant. So they started using it in children. And of course, parents have a lot of control in what very young children can eat. So it's a little bit easier in them because you have to be very, very disciplined. So this is a ratio where you see, this would be an example of a 3-to-1 ratio. So a 75%, excuse me, fat content would mean that for every gram of protein that you eat, or combined protein and carbohydrate, you would have to eat 3 grams of fat. So think about that. If you had a 3-ounce hamburger, no bun, no condiments, you would want to make sure that you had, that would be 9 grams of something really heavily loaded with fat. And some readily, easily accessible things would be bacon, or drinking heavy cream, or using lots of mayonnaise. Mayonnaise that has no added sugar. That's really important. Things like that. So it really is the high fat content that puts your body into the ketosis state. So right now, keto is all over the web, all over. There's celebrities and athletes that have jumped on the ketogenic diet, but I want to impress upon you that the way it's used to treat epilepsy is not the same. They really fine-tune to each person what ratio they need to live on. And it's labor intensive. You have to weigh and measure everything you consume, and you have to make sure, I mean, this is a pretty simple ratio, 3-to-1. And I'm combining protein and carbs to say these two together are the 1, and this is the 3. But once you get into those, you're on a 0.275 to 1.25 type thing, it can get quite complex and very, very time consuming. But there's a lot of support for it. The Epilepsy Foundation has lots of information to share with families who are starting this. And usually your neurologist will connect you with a dietitian who's very, very familiar with the ketogenic diet to help things get started. But you can say goodbye. There are no cookies, no candies, no cakes. There's no cheating on this diet. This is not what it's like. You're really eating measured amounts of protein, little to no carbohydrates, and you're really living on a lot of dairy, a lot of oils, avocado, coconut oil, MCT oil, things like that. And yes, you can have bacon and you can have hot dogs and sausages on this, but you have to be very careful where they're coming from so that you can be sure that they're not being made with a lot of additives like sugar and preservatives. Less stringent and a little bit easier for people to follow would be the modified Atkins diet, where you don't have, oh, and I didn't even tell you that your drinks are counted into your grams. So there's no restrictions on your fluid, on how many calories you consume. It just monitors your carbohydrates and encourages you to eat healthy fats, like I mentioned. So it's a lot easier. You've got a lot more choices in food on this modified Atkins. And then the low glycemic diet is typically, it was developed for people living with diabetes, but it teaches people how to focus on carbohydrates that don't spike your blood sugar. So for example, if you were looking at carbohydrates and you said, should I have a sweet potato or should I have spinach? Well, that's easy. Spinach is going to have a low glycemic index. It's not going to spike your blood sugar as much as it's not that a sweet potato is bad. We're not saying bad and good, bad and good. We're just saying that's going to spike your blood sugar. The sweet potato would be a much better choice than, say, a bagel or a muffin. Okay, so they just all have different low glycemic rates, all right? And they'll use these modified Atkins and low glycemic diets as an add-on therapy with the anti-seizure drugs. There are children who have actually been able to wean off of their medications on the ketogenic. Not so much on these, but on the ketogenic, they might be able to if it's really a treatment that works well for them. You have to be vigilant. You have to be a knowledgeable, informed shopper. You are going to spend shopping trips at the supermarket. You're going to have to double the time because you have to read every label. You have to count the sugar and fiber grams. Dietitians teach you how to do this, that the total carbohydrates, you can actually subtract. If something is very high in fiber, you can subtract the grams of fiber. Because it'll offset the number of grams of sugar to lower that carbohydrate number. But there's so many other things besides food that you have to be careful about, particularly on the ketogenic. And some of those are listed here. How many of you think about the toothpaste you use every day or the mouthwash? These have hidden sources of carbohydrates. What about over-the-counter medicines? Particularly for children, they often sweeten them to make them taste good so that the kid will take them. So they actually have to look at all their medications, particularly if they're so young that they can't swallow pills, and make sure that the liquids don't have added sugars in them, that it's not something that will throw off their ratio on the ketogenic diet. Let me take a quick peek at the window and see if any of you have questions. I do not see any questions yet. All right, so I will keep moving on. So when a child becomes school age, it gets a little bit more complex when we look at these dietary therapies because they have to have their own food sent from home. Now, some companies out there are getting wise and providing keto drinks, keto shakes, we had a whole keto conference in January, and we had some of these companies attend that would give some convenience packaging to help parents, because otherwise the time spent measuring and packing up and sending the lunch to school and the snack to school with the child, there's two key pieces that are really important. Not only do they have to only eat what was sent from home, but they have to complete the entire meal with the recommended level of fluids to keep them metabolically stable. We don't want them to become too dehydrated. We're trying to minimize the side effects of the ketogenic diet. Could potentially be ketoacidosis, which can become quite dangerous. Dehydration if they're not drinking enough fluids, things like that. So they have to eat what's given. And some children, they get, eating and what they eat and drink can be a little bit of something that the child can control. So, we need to develop strategies about that when the child is, let's say they're sick, they've lost their appetite. That matters because, we're already skewing where they're getting their calories and energy from. All right. So if I'm sounding like doom and gloom, I don't mean to, but this is certainly something you want to do your homework about before choosing to get on it. Because what if you have multiple children? That's the other thing. So you've got the child with epilepsy who's on this really, really restrictive diet, but they're watching their siblings eat whatever they want. So there's all sorts of issues that need to be taken into account. Perhaps it's certainly a lot easier when the whole family is somewhat on board and eating most of the things like them, very similar foods, but not exactly. I would not ask the other children to drink a cup of cream, that's for sure. I wouldn't do that, but all right. So moving on from the dietary therapies, I did want to expand because I really didn't touch upon them in Epilepsy 101 is what's available When episodes of seizures last too long, or people that are prone to having multiple seizures too close together, what we call clusters, where they're really not recovering in between. So what we've been using here in the United States forever is a suppository called Diastat is the brand name, or diazepam is the generic name, and it's a rectal gel, and it is dispensed in this pre-measured syringe that you see here on the photograph, and it's got a full approval to be used by parents and non-medical caregivers. But it's still I was at a school yesterday where the nurses were adamant this is a controlled substance because it's part of the the valium family. So, no, we can't train unlicensed medical personnel. It has to be one of us to give in school. But honestly, it was FDA approved that babysitters, any caregiver can be taught how and when to use this as a rescue medication. So what you see here in the syringe, when you pull off the cap, it's got a long applicator prong. And people are like, oh my God, look at that. Well, this is not something that you're injecting or jabbing into a person like an EpiPen. I tell people when I train them how to administer Diastat, it's that long. The prong is long because it has to make its way to the opening of the rectum past the cheeks, you need that space. And then you see here, it has this little guard. It's like a guard so that you can't insert it too far. And then you're just slowly depressing the plunger to a slow count of 3 seconds. 1, 1,000, 2, 1,000, 3, 1,000. And then you're keeping the applicator inserted, counting to 3 again, 1, 1,000, 2, 1,000, 3, 1,000. And then you slowly withdraw it, and you pinch their little cheeks closed to keep as much of that medication in there as possible. The nice thing about it is that we know it works. Is if there's a child whose tonic-clonic seizure is over 5 minutes, this Diastat is going to stop that seizure in between 2 minutes and 15 minutes. It's going to stop it and hopefully prevent a dangerous situation of status epilepticus and interrupt that seizure. Now, last year, we were all thrilled to have midazolam receive FDA approval as a rescue medication as well. And under the brand name Nasolam, it is now available for neurologists to prescribe. So certainly in a school setting, this is a lot preferable to a suppository, which has embarrassment and, let's face it, nobody says, hey, I want to have a suppository today. That's no fun. I think we're going to see so much more of this. But again, the nurses at yesterday's training were adamant and said, oh, no, midazolam has a high risk of respiratory depression. So I told them I'd do some research. The country of Australia never used Diastat as a rescue medication. That for decades, they've been using midazolam. So I am sure I'm going to be able to find some studies that will show that the risk of respiratory depression is quite low, because I can't believe they would have used it all this time if it had a high risk. So again, it's being used only for seizures that go over 5 minutes, or for seizures that are happening so close together that the person really isn't recovering. All right. And typically, not always, but typically, we're talking about tonic-clonic seizures here. Although people who have clusters of non-convulsive seizures, like absence or focal, maybe their neurologist might want a rescue med used to interrupt that cluster. But again, it's a little tougher to recognize those seizure clusters. But with a tonic-clonic seizure, if we're timing that rigid tonic phase and that jerking and shaking clonic phase, we can tell when it's ended in 5 minutes or less very clearly, as opposed to if it hits that 5-minute mark, we definitely want to have something like midazolam. Now, the nose is very restricted on how much liquid it can absorb. So the Nasolam or the Midazolam, is you see here, before we had the nice Nasolam hit the market, parents would have to purchase these little atomizers and attach them or screw them onto syringes that they would buy. The Midazolam would come in little sealed vials from the pharmacy, and they would have to draw up the correct dose. See the little markings on the syringe. So off the top of my head, I think it's something like 0.2 milliliters is what can be absorbed in each nostril. So because these medications work by body weight, you might have to do multiple, at least two, 0.2 up one nostril, 0.2 up the other nostril. And then if someone requires a larger dose, you're going to go back in and do it again, I believe, because we are restricted in how much can be absorbed through the nasal membranes. Oh, this is kind of out of order. This is just a better picture showing you what the Diastat looks like, how long it's been in use since 1997 here in the United States. The biggest, most common side effect is sleepiness. It's Valium. Knocks them out, puts them to sleep for a while. And we have millions of doses where we look at respiratory depression is not significant. It's like 0.002 out of thousands. So it's really, really safe to use, and it does work. It's just a less desirable method of dispensing the medication, certainly in a public place like a school. Okay, the doses, the nice thing about having these syringes is that the pharmacist sets the correct dosage. So the range is 5 milligrams to 20 milligrams, and there'll be this little green ready band that when the pharmacist sets the correct dose for that person's body weight, that's what they will, it'll be ready to go. You don't have to draw anything up. You don't have to measure it. It's all done. Okay. Oh, and here's the instructions that I told you. There's your little 1, 2, 3. I kind of jumped ahead on my slides. This is a video of Patty Schaefer, and you might know this lady over here, going through on a training mannequin how to administer Diastat. If you want to watch that at some point, I can send you the link. And here's the syringe. Oh, this is a much better picture showing what the Midazolam looks like. And then these little atomizers, this soft plug that you see at the top, these are separate. You have to attach them to the syringes. And then you can see how it's marked off in 0.5 milliliter to 3 milliliters. I'm going to look that up again. I'm pretty sure it's only 2 that can be absorbed in the nose. So as we come to, it's 1/4 already. My goodness, how time flies. So what's this outcome? I'm repeating this slide from Epilepsy 101 because it's important to give hope. It really depends on what is the underlying cause of a person's epilepsy. So there's some types of head injury, or perhaps somebody's developed it due to an infection like meningitis or encephalitis that really might make them a drug-resistant epilepsy. So that's why we have to look at, if we can determine an underlying cause, we depend on that. But we still see between 60 and 70% of people are responding well to being put on that first medication. Say, I'm combining that number I gave you of 47% on the first with subsequent treatments. They're saying that, you know what, we are hopeful that we can get good control for as many as 60% of people. All right, I'm thinking 70% sounds a little optimistic, but we do know that at that 36% of drug resistant, that we know that over 60 are getting that response. All right, and that the earlier we get seizures under control, the better off we are. We know that we can predict that, you know what, we're going to have better long-term. Over the years, the response is going to be much, much better. This is why your neurologist is always saying, we need to try this med, we need to try this med. And I know sometimes we're reluctant, but they know there's this phenomenon in our brains. Our brains are so miraculous. And particularly if you imagine with children, their growing brains are making new neuronal connections all the time. As adults, we still do it. We just don't do it at that huge exponential rate that children do it. So our brains can actually learn to seize. And what I mean by that is when we have recurring seizures over and over and they're not well controlled, it almost becomes the default pathway where the brain kind of goes to that overstimulation or overexcited point into a seizure. And this is why we really, really struggle. We want to get those seizures under control. And you just need to talk to your, it's a decision you have to make with your doctor. If the meds are really, really tough for you, well, then you need to look at, am I a candidate for surgery? Or should I consider a dietary therapy? Am I disciplined enough? Am I really going to stick with it? You know, am I going to be compliant when you look at those other choices? Because we know the sooner we get the seizures under control, the better. There are those lucky people. Again, this slide, these two slides, I did not write this information. These were written by a neurologist. And I honestly would like to debate it, but maybe my perception working at the Epilepsy Foundation is skewed, and that I'm not meeting and speaking to those people who can discontinue their epilepsy medications. But I know they're out there. I know children who have benign Rolandic that has a really like 70 to 75% of them can successfully get off meds during their teenage years. You know, I do know them, but 50% still seems a little bit optimistic to me, but great for them if they can come off their meds. You know, that would be fabulous. And the range is 2 to 5 years because, again, it depends on age of onset, type of seizure, underlying cause if it's known, and how conservative or progressive your neurologist is. You know, some neurologists are like, yeah, let's try weaning you off and see what happens, and others don't. We tried it with my daughter when she was 16, weaning her off her epilepsy meds, and that's when we found out that, nope, this is going to be a lifelong condition because the seizures did come back after a period of time. All right. And again, all of these treatments, no matter what they are, depend on how good are you at following the treatment plan outlined by your neurologist. This is key. I mean, are you taking your medications? Are you forgetting them? Are you having trouble affording them? I mean, and these are things that we want you to reach out to us here at the Epilepsy Foundation to see if we can help you about those problems, you know, to alleviate those problems and, you know, get on your meds and stick to the schedule. And then there are, as much as seizures are beyond your control, there are things you can control. So if you're having trouble with sleep, that's a huge trigger for people with epilepsy. So we want to help you develop strategies for getting a regular bedtime. And it's okay. If you're a night owl and you have a daytime schedule that allows you to go to bed at midnight and get up at 8 a.m., great. But just know that it makes it difficult when you're up till 2, 3, and 4 in the morning and then sleeping until, you know, noon or 2 in the afternoon. You're just completely off the circadian rhythms, and that does not help. We really discourage, neurologists will discourage adults with epilepsy from doing shift work. And by that I mean there are those jobs, police, firefighters, nurses, medical people, where they have a revolving schedule of working 7 to 3 for some period of time, and then they switch to 3 to 11 for some period of time, and then they switch to 11 to 7. That's really an accommodation that we would encourage a person with epilepsy to say, I can't be put in, they just don't adjust to that. It's hard enough for people without a neurological condition. It's much harder for someone with epilepsy. And we don't even like to see them on the graveyard shift all the time. Every once in a while, I run across a person who says, oh no, this is how I've worked all my life. I'm used to it. But as long as they live on a consistent schedule, that's key. And that's the key to it. We always want you to pay attention when you're getting ill, because fevers can lower the seizure threshold. Certainly any sort of gastrointestinal bug or flu or cold, it just lowers your threshold a bit while your body's fighting whatever else has come into play. I think it changes again, because seizures and the brain, the way the brain neurons work is an electrochemical process. I think each of these things slightly changes our brain chemistry, and that's what makes you susceptible to the breakthrough seizures. Same thing with major emotional stress. We release these certain hormones that must have an impact on that brain chemistry that makes it more susceptible to having a potential seizure. Anytime you're adjusting your meds, you want to pay attention to that. And again, if you are someone that abuses alcohol or certainly any sort of recreational drug like cocaine or crystal meth, I want to caution you to be very, very careful about that, because that definitely has a huge impact on having good seizure control. Oh, and there's the slide about the threshold. I repeated it. I thought this was a valuable one to bring back. So you see you have your factors. Here's your seizure threshold. This is usually genetically determined. And how many factors before you'll cross over that line and have a seizure? And look in your day-to-day lives and see if you can identify particular, obviously men aren't getting periods, so that's not going to be a problem for them. But you want to look at your alcohol intake. You want to look at how often you forget your medication. You want to look at how much stress you're under at work. We were having a big discussion about this at our support group meeting on Tuesday night. And then you get sick. How many of these things are going to push you over into a seizure? And this is just your list again. I'm repeating it from the last one because it's important. The factors that would make it likely. And then this is the tough conversation to have, is to talk about SUDEP as we come into the end of this presentation. I don't mean to be a Debbie Downer, but I want you to be an informed person, an informed patient, or an informed caregiver, to understand that there are more people dying of sudden unexpected death in epilepsy than there are babies dying of sudden infant death syndrome. And think about how prevalent new mothers are handed information about SIDS the day or the day after their child is born in the hospital. It's that important. It's a prevention tactic. Well, we feel very strongly at the Epilepsy Foundation that our neurologists should be having this. It's a difficult conversation, and it's not to scare people, but it's to inform them that it exists, okay? And that there's still so much we're trying to find out about it. And the stats, the risk is actually higher in adults than it is in children, and that the greatest risk factor is children or adults who have uncontrolled, frequent generalized tonic-clonic seizures, the convulsive seizures, all right? So if they have more than 3 of these a year, their risk for SUDEP goes to 18 in every 1,000 from 1 in 1,000, all right? That's a pretty big jump. We don't know exactly what it is. Research is looking at patterns of abnormal breathing, or their heart rhythms are out of whack, or perhaps there might be a genetic link they're looking for. And they're also looking at the specific brain regions, specifically at the back of your head and the top of your spine. Our autonomic body functions are controlled by that area of the brain back there. And our breathing, our heart rate, that's what I'm talking about. And they're thinking that, to put it in a really crude way, after a seizure, our brains reboot or turn back on after the seizure on their own. And they're thinking that some of the people who passed away from SUDEP, that something prevented that area of the brain from turning back on when it was supposed to, and that's why they passed away. So they are continuing to look at these different factors. So what can we do about it? God, now that I told you all the scary stuff, well, you know what? If you have uncontrolled seizures and you're seeing a private neurologist, I highly encourage you to look into making the trek into an epilepsy center. And living here in Massachusetts, I don't know if any of the people are from Rhode Island or Maine or New Hampshire on the call today, but you want to get a referral to an epilepsy center, and you can reach out to us and we'll connect you with travel assistance programs if you need them to get you there. Because you just want to have a second set, look at the situation and see if we can't get better control of your seizures. And then, follow the treatment plan, discuss it with your doctor, and then follow it as they ask you to. It's so key important. And keep your medical appointments. If you're lucky enough that you achieve control and you're like, I don't have to go see my neurologist, you will get to that point. I celebrated with a woman in her 30s who said, for the first time in my life, I don't have to see my neurologist every 3 months. I'm now up to 6 months, or I'm now up to a year. And we were celebrating each milestone because she had achieved that good seizure control. And it's well worth celebrating. Learn about yourself, become self-informed. Look at what stresses you out. Look at what causes you to potentially have a breakthrough seizure. They're different for everybody. I gave you a list of the most common, but you might be unique. And if you have one of the less common forms like reflex epilepsy, where people are really prone loud noises or will trigger a seizure, know that about yourself and invest in some good earplugs or use noise canceling headphones, when you're out and about and able to do so, things like that. So there are workarounds. People who have really photosensitive epilepsies, about 3% of people with epilepsy are photosensitive. You can do things like wearing sunglasses to help, reduce them. There are ways, or hats or things like that, hats with a brim, visors, things like that. I know I'm sounding like a nag, avoid the alcohol and the recreational drugs. Alcohol has a really unique role for the person with epilepsy. It's not just when you're drinking that's the danger, it's as you're sobering up. As the alcohol is leaving your system, there's some rebound effect that just makes it more likely for a person to have a potential seizure. And then if people do have frequent generalized tonic-clonic seizures at night, consider investing in some sort of monitor or bed alert system, supervision if you can. This is a tough one because as children grow up, having their own independence is a rite of passage. So we have to balance the risk against their emotional well-being. And, it's worth a conversation to think about that stuff before you automatically put a baby monitor in a teenager's room, that type of thing. But certainly if you have young children, you definitely want some sort of either monitor, or there's regular baby monitors where you can just listen for the sounds, or if you need a video attachment, there's something called a SAME monitor that has a video and is programmable to iPhones. So just we look at all of those factors. And then the last bullet, we should all be doing this, not just to avoid the risk of SUDEP, but we all should be doing this stuff. And it is important for people with epilepsy as well. So this was, let me see the time. Oh, I got 1 minute left. I just wanted to refresh your memory about the challenges associated with epilepsy. I did talk about this in Epilepsy 101 because it is so important. Sometimes we can't look past the big E. The epilepsy and the seizures is all consuming, and we interpret everything according to that. But you know what? Sometimes there might be a coexisting anxiety disorder or depression might have developed. that we really need to recognize and treat alongside with the epilepsy, that it's so important. And if you're an adult, let's have a conversation about ways to increase your social engagement, what you can get involved with. And if you're a parent of a child, you know what? I know you're busy and I know I'm laying one more thing on you, but don't wait for the kindness of others. You make your own child's social engagement and you lead and you teach them by example. And if you're have other children in the family, the siblings can also show how to just treat the child with epilepsy the same as everyone else. It's so key and so important. All right. And then let's all work together to help. Every time I think that the stigma has diminished, I run into some ignorance and I just shake my head and say, oh my gosh, we still have more work to do. If you happen to have a child with epilepsy and you're concerned about the impact on learning and behavior, we know it's there. Children and adults both experience short-term memory problems, which makes learning harder, particularly if the seizures aren't controlled. Anything they learned prior to that seizure, the tragedy is that it may have to be retaught because it's like that seizure went in and erased it. So just know that. Reach out to me here at the foundation if there needs to be some education for your child's teachers. Happy to do that. I am very accommodating and flexible. I really try to get in there and talk to them on their time frame. All right. And please be aware that learning disabilities like depression and anxiety can coexist with epilepsy. Kids with epilepsy do have a higher risk for developing learning disabilities. So maybe you need to have, certainly before they start school, you want to consider having a neuropsych to set a baseline when they're, I forget what the age is, what the earliest age is that they can do a neuropsych. I'd have to look that up. But you definitely want to have a baseline set. And then if you envision that your child is going to require an individualized ed plan, that's going to be the roadmap that sets what services you're going to ask for. You have to ask for the services. Rare and uncommon is the school system that just says, here you go, this is what you need. Oftentimes you have to make sure you know so that you're asking for everything your child needs. Those school systems do exist, but they're far and few between. All right. And as we wrap it up, we are at 102. I went over. I apologize. I didn't get to the behavior slides. We do see behavior problems in children with epilepsy. They are, let me see if anybody has to go. Can I continue on here? Somebody raise your hand. You can, I'm certainly going to understand if you're on your lunch hour and you have to go, but these slides have some really key information that I'd like to cover. All right, so I'm going to continue because people don't have their hand raised. So we are seeing higher rates of behavior problems in children diagnosed with epilepsy, but interestingly enough, it doesn't really match. It doesn't matter whether they have focal seizures or absence seizures or tonic-clonic seizures. It's not the type of seizure that matters. It's the fact that they have seizures in the first place, that they are not well controlled. And we have some certain anti-seizure medications. Maybe this will ring a bell. Keppra is a well-known one that has, as a matter of fact, the new Benzel, one of the selling points of that is that it's not as prone as Keppra was to having some of those mood changes or behavior changes that we would see in it. So sometimes it's the seizure medication we have to look at. But again, part of having a neurological condition is that it can cause some dysfunction in the brain that just makes them prone to behavioral issues. All right. The other big flag for seeing behavioral disruptive behavior in children is that they're having subclinical seizures. So a subclinical seizure is that if we had them hooked up to the EEG, we would be seeing this abnormal activity, but we would not be seeing any outward physical signs of their seizures. So they're called subclinical because they're not presenting in the body outwardly, but the brain is still not at a baseline. It's not optimal at all. And this has a huge impact, not only on behavior, but as you can imagine, on learning as well. So you want to pay attention if your neurologist says, geez, I'm seeing some subclinical activity, and ask them to explain that and how we can proactively help the child if they're experiencing these. And that kids who do have uncontrolled or recurring seizures, they're more likely to have these in between the seizure discharges. And what they call it is a transient cognitive impairment, that it's really impairing their ability to learn when they're having these in between the seizure electrical discharges in the brain, all right? They tend to be, this is why a lot of children with epilepsy also fall on the autism spectrum, is because these interictal discharges or transient cognitive impairments are causing them to miss important social cues. And as you can imagine, their seizure is taking up time and attention in their brain. So they're missing those day-to-day interactions that provide those cues that you and I all learn, facial expressions, body language, as well as what is spoken. You know, so if you have an absence seizure where you're blanking out for 5 or 7 or 8 or 10 seconds or more, you might be missing these, okay? And the last bullet, when I pulled that out of the study that I took this information from, you know, I wanted to say, duh, yeah, we improve the seizure control. Yeah, we're going to see an improvement in their behavior. So if they are becoming problematic for your family, you know, we can look at things like ABA, which is applied behavioral analysis techniques. We could look at cognitive behavioral therapy to see, you know, there's all sorts of things that we have present and that can be brought into the schools as well to encourage the desirable behavior that we want to see. All right, promise there aren't too many more. So out of the wide list of what can happen and coexist with epilepsy, we have oppositional defiant disorder, which again, we don't know why it happens, but there are some environmental as well as genetic factors, but you typically will see them. They begin before a child is 8 years old, and they're just, everything is an issue. Everything becomes, you know, the simplest decisions just start an argument, you know. They can progress to seeing some sort of aggression, and it can cause a lot of problems, needless to say. And right now, currently, the only treatment we have is individual and family therapy for this. We also have attention deficit disorders, attention deficit hyperactivity disorder, that both children and adults, I'm not sure people realize that adults can suffer from an undiagnosed ADHD. And it really has an impact, particularly on executive functioning, you know, how they organize their tasks and their thoughts and problem solve, things like that. And we definitely want to have a diagnosis and treatment. And I have, oh, sorry, didn't mean to change that quickly. The treatment does include medication, and even though we're reluctant to add a medication to a child who's already taking epilepsy meds, I have talked to pediatric neurologists who are taking part in our school nurse Project Echo, and they have said that this ADHD can be so disabling, more so than the epilepsy, that it's really worth treating, and that they do know which drugs they can choose to add to the epilepsy treatment to help bring relief. So don't automatically say, oh my God, another drug, another drug. Have that conversation, because sometimes if the ADHD is what's causing the behavioral problems, you know, it can be a game changer for that child, that they can now focus enough to learn good social skills, to pay attention in school, things like that. Okay, so these are some of the resources that I have available to send to people if you want. This is a sheet for parents so that they can organize the information about their child with epilepsy so that they understand what to give the school, just to make it a little easier. This is our template for a seizure action plan. This will be signed off by the prescribing neurologist, and it should be very specific, the type of seizure, particularly for the emergency response. And then these are for seizure tracking tools. There's a ton of online tools that I can share with you, but if you're still a person who prefers paper and pencil, we have these two, an observation record, which has all the symptoms of a seizure listed down here, and you can track when it happened and how long it happened. Or I give this out on the left, the seizure description sheet, which is a pictorial representation of what occurs during seizures, to teachers, because I tell them, you know, maybe this is easier for you to just run over and circle or check what you observed and just write the date and the time that you observed it. Okay, well, thank you for hanging in with me if you did. I went 11 minutes over our allotted time. I apologize. I do tend to go on and on. Let me check the question panel, see if anybody had any questions. I do not see any questions. I want to thank each and every one of you for having your time. I will grab your email addresses from the registration list, and I will send you handouts to this PowerPoint presentation if you're interested, as well as some of the resource tools. I'm going to send you the information on the importance of seizure tracking. I'm going to thank you for spending this time with me today and hope you enjoy the rest of your day. Thank you very much.